very good for neuropathic pain. So we use them in diabetic neuropathies. And we've mentioned several. It can certainly be used for depression. It's very cheap now compared to the SSRIs. So they're still out there, and they are just deadly drugs. When you think about TCA overdoses, you think about cardiac toxicity. So just looking at, they're antidepressants, but they affect almost all the neurotransmitters. So looking down through there, this is important. It will be helpful if you'll keep this in mind because it'll make the presentation make sense. So they block cardiac fast sodium channels, and that's what leads to most of the arrhythmias. So a lot of the mortality from TC overdoses comes from the cardiac toxicity. They also are anticholinergic. So if you think about the side effects of the TCAs, very common mild anticholinergic side effects, but we see them then in overdose. They're also active on alpha-1 adrenergic receptors, so they have vascular effects. Hypotension can be a severe side effect of an overdose. In fact, sometimes it's so refractory to care that they will die from the hypotension. They affect histamine receptors, so you'll get leakiness of vessels will occur because of that. They also work on GABA receptors. So what do you remember about GABA receptors? When we talked about benzodiazepines, what is GABA? In terms of a neurotransmitter, how would you classify it?
Excitatory or
It's
inhibitory.
inhibitory, right. So benzodiazepines potentiate that. So think about benzodiazepines. We use them for sedation, calming, anti-anxiety. So when you remove that inhibition in the brain, then what can happen? Seizures. Okay. So if you'll think through those things that you already know, you've seen in other places, then the toxicity will start, I think, to make more sense. So again, in therapeutic doses, kinetically, rapidly absorbed, it's lipophilic, so it gets everywhere. Lipophilic drugs usually have high volumes of distribution. They go everywhere. So that gets part of the problem. They're metabolized by the liver, 2DC, and glucuronidation. The 2DC, what's interesting about that is that if I tested all of you in this class, there would be a wide range of how fast or slow you metabolize through that pathway. And so that will show up sometimes in an overdose situation, is that slow metabolizers get very toxic very fast. The other thing with TCAs is that often when they come in, they'll be obtunded, or they can be talking to you and crash in a matter of seconds. So it can be a very fast deterioration, usually because of the cardiac or the hypotensive effects of the drug. You can get decreased rates of metabolism. It's a saturable enzyme system, so you can just not be able to get rid of the drug as quickly. It also has undergoes enterohepatic recycling, so whatever gets to the gut that's active, the liver takes back up and just keeps throwing it back into the system. So that is part of what's going on as well. So all of those pathways get overwhelmed. So in terms of physical findings, cardiac toxicity, number one, conduction abnormalities, extremely common because of the actions on those sodium channels. So you see conduction velocity decreases, repolarization increases, and absolute refractory periods increase. So VTAC, VFib, very common, very malignant arrhythmias, one of the causes of death. So the higher the amount that's taken in, the wider that QRS gets. So you get a lot of QRS prolongation. Hypotensive because of the alpha-1 adrenergic receptor activity. And then also you can see a sinus tach because of the anticholinergic. Also due to you're getting a decrease in total peripheral resistance, so you get a reflex tachycardia. So some of it's drug effect, some of it is compensatory effect. In terms of CNS toxicity, the antihistamines can certainly make them, sedate them, make them obtunded. Delirium can come because of the anticholinergic effect and the seizures. We talked about GABA effect. So, top of page 8. Presenting symptoms: elevated temperature, flushing, so you get that vasodilation, dilated pupils. Again, if it's a co-ingestion, it may be that will be moderated by what other drug they've taken. Delirium from the anticholinergic, intestinal ileum, or so they'll get a blockage. They can get slowdown of the gut and blockage. Urinary retention, anticholinergic effect. So EKGs, you need to slap an EKG on them very quickly and monitor for that. The signs of toxicity is QRS prolongation greater than 100 milliseconds, most likely thing that you'll see. It is an indication to use bicarb. So we use bicarb here to arrest the arrhythmias. Other abnormalities that are seen are in with the R, the height or amplitude of the R wave, and the S part of that complex. So often what you'll see is your amplitude goes up in your augmented leads, and then you get this kind of slurring of the S wave. So it goes down, and then it's just like it's kind of lethargic to get back up. That's classic for TCA. So QRS widening, changes in the R amplitude, and then the S wave is it's kind of that delayed slurring is a good word to use for it. So management, of course, you're always going to look at airway, breathing, and circulation. If the patient is hypotensive, you do not want to put them on, use an induction agent that would worsen that. Because that hypotension can be profound and refractory, so you have to be very respectful of that in a person in this overdose situation. Bicarb is the drug of choice for arrhythmias. Usually you can push, they come in amps, you can push them IV fairly quickly. If they're non-responsive, you can repeat it, and then you can put them on an infusion. The expected response is you expect that QRS complex to normalize, so narrow in time, and amplitude of the R to come down, S wave to look more normal. So you're going to keep them on an EKG as you're treating them. Again, always look at potassium levels. Always look at, in your older patients, the amount of sodium in sodium bicarb is huge. So volume overload could be a problem. Heart failure, pulmonary edema could be a problem when you're giving them. If it's seizures, then you're going to use a benzodiazepine. You can use diazepam. A lot of people use lorazepam because it's very quick in onset, and it's also short in duration, so you can turn it on and off. You can use activated charcoal. It's recommended you just use a single dose. I know that I told you that if drugs that undergo intrahepatic recycling usually do better with multi-dose. That's been looked at, doesn't seem to be effective, so the recommendation is just a single dose. For hypotension, vasopressors, if the sodium bicarb and other relieving the arrhythmia doesn't do it, then you can look at a vasopressor like norepinephrine would probably be the drug of choice. If that doesn't work, you can use hypertonic saline. So normal saline is what percent? 0.9%. So hypertonic is 3%. Okay. You can use it in small doses to expand volume, but it's limited to about 2 or 3 doses. But that is another intervention. Refractory arrhythmias would be magnesium. Should be coming second nature to you when you see malignant arrhythmias. Arrhythmias that don't respond, is magnesium needs to be added. Lidocaine, which is a class 1B, is a kind of last drug of choice. We don't use this unless we cannot get the arrhythmia to respond to other interventions. Because it is a lipophilic drug, people have used lipid emulsions. Most of the time you'll see caveats with lipid emulsions is that call a medical toxicologist, call a poison center to get advice on how to do that intervention. Questions about the TCOs? Question about overdoses in general? Okay, let's look at the topical anesthetics. So have you all talked about local anesthetics? Yes? In what context? What have y'all done in this module that you've talked about?
Oh, this one.
Not in this one? Okay.
Lidocaine don't use.
Don't be stepping on fingers, toes.
Oh, very good. Why not?
Vasoconstriction.
Yeah, if you have compromised to their perfusion anyway, you'll just make it worse. You'll just kill it off. Okay, that's good. That's a good lesson. Okay. So you all haven't done, you do, in capstone you do like your suturing and things like that? Okay. All right, so we'll go through these. We'll do these things. So for the most part, we're trying to kill off pain. We're trying to do something to somebody or relieve pain so that we can do something to them. So we want something, so in terms of a drug that we would want, what kind of characteristics would be favorable?
Fast acting.
Pardon?
Fast acting.
Fast acting, rapid. You want it to, as soon as you inject it, you want it to start causing an effect, right? Okay. And then, do you want it to last for a while? Maybe, but you would like it to reverse pretty quickly, all right? When you put Novocaine in your mouth, you don't want that to happen all day long, right? Okay. So we would like it to last as long as we're going to do a procedure, right? We're going to stitch somebody up, we want it to last through that. But we don't need it to last much beyond that, because beyond that we'll take care of whatever symptoms they have by other means. Okay, so we're going to talk about the characteristics that will make something fast-acting and will terminate its activity. Okay, so do most people enjoy getting local anesthetics? No, why not? It stings. Mostly it stings because the pH is low. So we'll talk about things that you can do to comfort people. Other things that people don't like, being stuck with needles. So with kids that brings particular problems, and with a lot of adults it does too. So we'll talk about ways to modify that. So for the most part, if you look on page 2, if we can get the drug into the subcutaneous space, that will usually affect or cause the effect that we want. Intradermal you can do, it's more painful, it's just not necessary, so subcu is usually what is affected. The type of pain fibers that you are trying to affect will also determine onset and duration. Also, how far away from the point of, or the nerves that you inject also will have another effect. So will onset and mostly affect onset. So if you're trying to do a nerve block of a nexus of nerves, that usually takes longer. It may take 30 minutes for the drug to diffuse to that. So the closer you can get the drug to where you're wanting to do the procedure or whatever you're wanting to knock out, the more rapid the onset. If you look down under classification of local anesthetics, this is important. There are amides and there are esters. For the most part, we use the amides. So if you look at those, you'll recognize a lot of them. Lidocaine, most common. Mepivacaine is a very similar to lidocaine, we just don't quite use it as much. Bupivacaine is the most potent, most long-acting. So when you need a drug that's going to last a long time, or you need quite a large amount of anesthetic, that's the drug to go to. Some of these drugs can be used in pregnant women, some of them cannot. The reason they can't be used in pregnancy is often because the baby's liver can't metabolize it. So it's usually a fetal effect, fetal liver effect. In terms of the ester agents, we really don't use them very much. Now, Novocaine we do. In the mouth, you can use it in the skin. Most of the time we don't use them. But if you've got somebody who has a true allergy to an amide, then an ester may be the way to go. So that's why it's important to know what are amides, which are esters, because of that. So under that last bullet under classifications, lidocaine is xylocaine, bupivacaine is marcaine, bupivacaine is carbocaine, not very common, procaine is novocaine. So most of those you've probably heard of, yes? Or you've been injected by it. Okay. So the potency of these anesthetics is related to their lipid solubility. Okay. The more highly lipophilic they are, the more potent. So if you look down there, bupivacaine is the most potent. It's the most lipid soluble. Next page, speed of onset is related to how lipid soluble it is. The other is the pH of the solution. The more likely it stays in, the greater fraction is non-ionized, like we talked before, the more active it is, the more rapid the onset. So sometimes providers will add bicarb to a solution, an anesthetic, not only to make it more comfortable to inject, but also to increase onset or speed up onset. The solution concentration, the more potent it is, usually the more rapid the onset. Okay, so a 2% is usually more effective than a 0.5% in terms of speed of onset. But all of these are fast. I mean, they're minutes. So it isn't like we're talking about 1 hour versus 2 hours. They're all pretty quick. Site of injection, again, subcutaneous is almost immediate. Intrathecals are very rapid. It's those brachial plexus blocks. So it's a nerve block that usually will take the longest. Ultrasound can be used to guide where you inject. It's usually the distance is the biggest problem there, is the distance that you have to inject from where the nerve is located. Duration of action, they vary widely. And these, I want you to know these. I want you to know what a short acting is, which are moderate acting, and which are long acting. So procaine, shortest acting, remember, that's usually in your mouth, wears off in a few hours. Moderate acting, lidocaine, and the bupivacaine, those are the more common ones used. And then long acting, bupivacaine. Keep that one in mind. Differential blockades depends on the type of fiber that you are trying to anesthetize. Small fibers that usually carry pain, usually are fairly responsive. But myelinated versus unmyelinated will make a difference in terms of how long it acts. If you look at the very bottom, nerve blocks in a typical setting know this sequence. So sympathetic function is usually lost first. You get some vasodilation because everything relaxes. Loss of sensation to sharp pain, temperature, and pressure is second, and motor function is lost last, if it's lost at all. Can't you usually do your mouth after you've had Novocaine? Yes, so you don't lose. So often a good anesthetic won't do that. You will lose your pain sensation, but you may not, and you may have some dulling of touch. Can you touch your mouth after you've had Novocaine and feel it? To some extent you can. You can feel pressure. Can you not? You can feel pressure. You may not be able to feel touch. Okay. Top of page 4. So we will add things. So you talked about, Caleb talked about adding epinephrine. So epinephrine is what? What does it do when we put it in a tissue? Vasoconstrict. So why would we use it with the local anesthetic?
Decrease bleeding.
Okay, decrease bleeding, but really it's to do what else? We want to trap it. If we don't want the drug to go very far, it will stay there. Okay. So we can use it to localize the drug effect, decrease bleeding. It also decreases the potential for toxicity, especially if you are injecting into a very vascular area. You are going to get some absorption of this drug. It's going to enter into the vascular space and will distribute it. So you don't want a lot of epinephrine circulating. You don't want a lot of anesthetic circulating. So there are systemic toxicities that can occur from your injecting a person, especially in a highly vascular area. So in using that epinephrine, you can decrease the amount of drug that is absorbed. The side effects, though, are just like if you gave somebody epinephrine. So tachycardia and ischemia would be the two major ones. So you want to use lower concentrations, which would be that 1 to 400,000 in patients who are at most risk for cardiac ischemia, so your older patients with heart disease. So be careful. Sodium bicarb can also be used for comfort and also to speed onset. Be careful when you do that because bicarb, let me just say one thing, is that never do something to a drug that you do not know what the consequence is. You will see when you go out there, a lot of people, a lot of providers are going to do things to drugs because they figured out that works better for whatever they're doing. But I'm telling you, don't do that unless you know that what you're doing is not going to change the chemical properties of that drug or how it's made unless you have looked into it. Most of the time you can call a drug company and they will tell you they have healthcare professionals that serve as drug information specialists for their product. You can ask them, if I do this to this drug, what's going to happen? Sometimes they can tell you and sometimes they can't. The FDA regulates how much of that they can tell. When I worked more in the pharmacist realm, I would get calls from physicians all the time. Okay, this is what my patient says they're doing. If you ever get on and read patient blogs, they will scare you to death because the amount of information that flows between people, like, did you do the gummy bears, or it's just you knew that they were doing it with the?
No, I found Facebook posted, I didn't do it.
Okay, see, it's that kind of stuff. They share information, but they are sharing it with this much knowledge, and there's this much knowledge that would make you not do that. So you may be in situations as students where you'll have to do things because that's what your preceptor tells you. But I'm telling you, I would always go back and look. I'd always go back and ask and see if what people are doing to a drug is going to change it in a way that they're not expecting. I'm not saying this to denigrate them. I'm saying that people act often out of ignorance, and that some more knowledge might change what they do. Choice of anesthetics. So we're going to walk through just the most common ones. So lidocaine. Usually they will come in a variety of concentrations, and the amount that you use is just going to be dependent on child, adult, also the amount of area you're trying to cover. One thing, take away, two things, take away. One is that there is always a maximum dose, and that the dose is usually milligram per kilogram. It's weight-based. I don't think many people ever go to figure that. They just have a known quantity that they use, but realize there are maximum doses. You would like to stay at least 20% under that max dose most of the time. So not ever pushing it right up to the max dose. So I want you to know that. Use higher when you're, and the other thing is when you're using epinephrine, you'll have to use a higher dose. Okay, so the milligram per kilogram dose is higher with epinephrine than if you're not using it. And there is a max dose. Onset of action, top of page 5, very quick, 2 to 5 minutes. Duration is 30 minutes to 2 hours for plain lidocaine, it means without epinephrine. A little bit longer if you're using epinephrine. For Marcaine, longer duration of action, a little bit longer than lidocaine. It's contraindicated. One thing you should go down through and mark is that it's contraindicated for pregnant women. This is one of those where the fetus can't metabolize it. It's good for longer procedures because its duration of action is longer. It's very lipophilic. Again, you can use it with or without epinephrine. Higher dose with epinephrine, there are max doses. Onset of action is about 5 to 10 minutes, a little bit slower than lidocaine, and a duration of effect is about 6 hours. For carbocaine, very similar. Again, pregnancy is a relative contraindication to the use of the drug. Again, you can use it with epinephrine or not. Doses are based on which one you use, and use a higher dose with epinephrine. Onset of action is 2 to 5 minutes, duration of about 2 hours. So again, similar to lidocaine. Indications for the local anesthetics are listed there. Probably a lot of these you've either experienced personally or you already know about in terms of skin surgery, open wound repair, abscess draining, removing a foreign object, vascular access procedures, lumbar puncture. Contraindications, let's look at this. Allergies. Patients will tell you about allergies. This is like allergies to other drugs. Sometimes what they interpret as an allergy is not a true allergy. Some people are allergic to the preservatives. They do make preservative-free local anesthetics. But that is something to establish if it is due to a preservative or an additive. If it's a true allergy, if you can discern that it's a true allergy, then using a different type. So if they're on an amide, you could use an ester. There's not a lot of cross. If they're allergic to an amide, they've had a true allergy, you need to be careful about using another amide. If it's an elective procedure, then you can put it off and have them tested. If it's a more critical, then you may have to go to general anesthesia instead of local. Okay? So the biggest thing is trying to figure out, am I dealing with a real allergy, and what would that manifest itself? What would the patient tell you that would make you worry about a true allergy? Okay, so more anaphylactic. If they've had widespread hives, they've had difficulty breathing, respiratory arrest, those kinds of things, then you would be more concerned. If it's a local effect, you'd be less concerned. Okay? The more elective it is, the more time you have to figure out what to do. The more expedient you need to be, and you're worried about a true allergy, go a different route. Okay. Medical conditions. Do not use epinephrine with the following: large wounds. If there's an underlying condition, hyperthyroidism, pheochromocytoma, why would you worry about that?
Precious.
Blood pressure, severe hypertension, coronary artery disease. Kayla told you, digital anesthesia in patients with compromised digital circulation. Okay, that's a duh. That should be pretty obvious. Periorbital infiltration in patients who have narrow angle glaucoma, so you can make it worse, kill off their eye. Using local anesthesia for large areas is not recommended, just because the amount of drug, you're probably going to exceed the maximum amount that's recommended. Drug interactions. So epinephrine is contraindicated if the patient is also on this drug. So Latuda, which is an antipsychotic, we talked about it in psych. You can get fairly profound hypotension. There are alkaloids, you can increase blood pressure. Beta blockers, it's less of a problem with cardioselective. If they're on a monoamine oxidase inhibitor is a more relative contraindication, and then the tricyclic antidepressants. So think about drugs, now Latuda is just different, but think about drugs that are vasoconstrictors and blood pressure, and that will help you remember those. Methods to decrease injection pain, again, you can use bicarb or you can warm it. So warming helps. Bicarb raises the pH. Most local anesthetics come in at a pH of about 3 to 5. That will burn. So if we can get it up to a pH of 5 to 7, most patients will have less discomfort, so you can use sodium bicarb. The only problem with it is that it makes the solution usually less stable. So you would need to probably dispose of it. Don't buffer a multi-dose vial, because you'll lose it, and those are usually more expensive. So shelf life of a buffered plain lidocaine is 1 week. If it has epinephrine in it, it's 24 hours. So just be aware of that. Anytime you change pH, you are usually going to change the solubility of a drug or the shelf life of a drug. Other are distractions. So physicians get really good at this. I always listen to them to see what they'll do, because you can pick up ways that people use distracting behaviors. So using TV, children, talking to them. I notice most doctors just are talking to you a lot when they're trying to do something to you that might cause you discomfort. Pinching or vibrating or rubbing the area before they inject it. Did you all get your flu vaccines? Everybody? Okay. Did they come over and do it? They told me they were going to do that. No? So you still have to go over there? Okay. Using smaller needles. Remember, the higher the gauge, the smaller the needle. Usually the more comfortable it is. Slowing the rate of injection down. Sometimes that will help. Just the infusion rate will help. Using the smallest volume you can will help as well. Injecting at a 90 degree rather than a 45. 90 will usually help you get better sub-Q than a 45. Usually ends up being intradermal, so be careful with that. Complications. Systemic would be CNS and cardiovascular. This is usually when you've used a lot in a large area or in a very vascular area and you've gotten absorption. So keep in mind the cardiovascular effects, CNS effects. So the CNS would be metallic taste, tinnitus, tingling of lips, agitation, seizures. Those are fairly uncommon. Cardiovascular would be bradycardia, decreased myocardial contractility. Is going to be a problem in younger people, but it might in older folks. AV block, vasodilation, ventricular arrhythmias, cardiac arrest. So being mindful of where you inject and how much is important. The allergic reactions, if it is more localized, looks like more of a contact dermatitis, then treat it as such. So vesiculations, blistering, just local, you treat as a contact dermatitis. Urticarian anaphylaxis, you're going to have to treat like you would any other anaphylaxis with an emergent treatment. Questions about those? Okay, let's take a break. Come back at 10 till.